everyone, and welcome to the Surgical Ergonomics podcast, where we will be discussing everything related to surgical and procedural ergonomics, the people, ideas, and technology that will help enhance your physical wellness and career longevity. I am your host, Geeta Lal. I'm an academic endocrine surgeon, speaker, consultant, and surgical ergonomics coach. Having experienced work-related musculoskeletal injury myself, I am committed to increasing awareness of and developing solutions to counteract the impact of poor ergonomics on the professional and personal lives of healthcare workers in procedural areas. Today's episode is sponsored by Q Optics. Surgeons, your neck shouldn't pay the price for precision. It's time to demand loupes that are built for you. Q Optics is more than magnification. Custom crafted through the lens loupes engineered and tailored to your unique facial structure and surgical posture. The ultra lightweight titanium build eliminates pressure points, red marks, and the chronic neck and shoulder pain caused by heavy, bulky, outdated optics. With the exclusive True Fit measurement system, each pair is precisely tailored to your unique facial structure, delivering a customized, stress-free fit and all-day comfort. The Ergo Direct Vision loupes with up to 60 degrees of declination keep neck flexion under 15 degrees, or go zero flexion with the Ergo Angle Deflection loupes for a straight-ahead gaze and complete ergonomic relief. And with crisp, edge-to-edge clarity within an expansive peripheral view around the telescopes, your field stays wide and unobstructed. Transform your OR experience today with a 45-day trial and exclusive pricing for listeners of this podcast. Visit qoptics.com/Dr. Lal to learn more and schedule your demo with a local representative. And again, don't forget to use the code Dr. Lal to claim your discount. Your work demands precision. Your body deserves relief. Q Optics, designed for comfort, built for performance. By the way, Q Optics has also provided us with an Ergo Angle Deflection loupes and headlight combo giveaway. The details will be provided at the end of this episode, so stay tuned. Well, hello everyone, and welcome to another episode of the Surgical Ergonomics podcast. In today's episode, I'm really glad to have as our guest Dr. Jeremy Greenlee. Dr. Greenlee is a professor of neurosurgery at the University of Iowa, specializing in neurosurgery with a focus of both adult and pediatric cases. He is also the Arnold H. Menezes Chair in Neurosurgery, a Vice-chair, and a professor of pediatrics. His research interests include neurophysiology of the frontal lobe, endoscopic and minimally invasive neurosurgery, and the treatment of pituitary tumors and movement disorders. Good evening, Jeremy, and welcome to the podcast.
Thanks very much, Geeta. Great to see you, and thanks for the invitation.
Of course. So, Jeremy, just as a way of getting started, could you just tell our listeners a little bit about yourself, including your training background and how you arrived at your current role?
Sure. So I grew up in Indiana and went to college in Michigan, went back to Indiana for medical school, and then moved to Iowa City in 1998 to start my neurosurgery residency. And trained here at Iowa and liked the place, obviously. I did go away to Australia for 6 months for a fellowship.
Okay.
And that was in minimally invasive neurosurgery, primarily intracranial surgery. So I came back and joined the faculty at Iowa in 2005, and my practice has evolved over the years. So I used to do spine surgery, about half of my practice and half was cranial. And then just kind of gravitated, and now I don't do any spine surgery. It's all cranial surgery. So brain tumors, skull-based tumors, endoscopic endonasal surgeries, and deep brain stimulators. It's a little bit of an odd mix, but fun and interesting and rewarding. So I like dealing with the brain.
Wonderful. So glad that you shared that. So I have to share with our listeners, though, that I think Jeremy and I, just hearing now that you said that it's been since 2005, I started at Iowa in 2004. And I recall meeting you when we were, I think, both somewhat newish attendings. I was still doing general surgery call back then. And I think we met either, one evening during a removal or replacement of a VP shunt. I think it was one of those cases. However, what kind of got us talking about ergonomics and injuries was the fact that many years later, I actually turned to you, Jeremy, for advice when I was at the worst of my neck and jaw pain. I had had an MRI of the spine, the C-spine. I had been seen in the pain clinic and was contemplating a cervical steroid injection procedure. And I wasn't sure if it was the right thing for me. And I think I just reached out to you to get some advice. And despite, your practice having gravitated away from, doing spine surgery, you were, very compassionate, present, listened to my concerns and explained things to me about the pros and cons of kind of proceeding with that sort of procedure. I think you did refer me to one of your spine colleagues who I then saw a few days later. But I remember at that time, something that you said, and I mentioned I'd been using Loupes. I had this pain probably from using Loupes for my endocrine cases for a very long time. And I remember you said, well, yeah, Loupes cause all sorts of issues and pain in the neck, etc. And that you shared with me that you had actually stopped using them a long time ago because of those reasons. So, would you tell our listeners today how exactly Loupes can cause detrimental effects on our spine and probably especially the earlier models, which we all sort of got during our training and were using for a long time?
Yeah, so when I trained, we used Loupes basically all day long, every day.
Mhm.
As chief resident, we would operate, and it was Loupes and a headlight every case.
Exactly.
So the headlights were bigger back then. The Loupes, like you say, were the fixed kind of angle 3.5x.
Hmm.
They're
Hmm.
great visualization and super helpful in that sense, but that fixed angle and just that weight on your head. I mean, I remember so we do 2 years in the lab at Iowa, and then you come out, do your chief resident year. So you're not used to doing that. And I mean, it was fatiguing and go home at the end of the day and have headaches and neck pain and neck stiffness. And eventually you get used to it.
Hmm. Hmm.
Um, but then as faculty, when I was doing less cases, I'd put a Loupes and the headline on and it'd be like the same thing all over again. And the Loupes have gotten better over the years, and now they have kind of variable angle things, and the headlights have gotten lighter. But because of that, I kind of gravitated towards using the microscope,
Mm.
which is more of a kind of a straight looking ahead, more natural ergonomic position. And it's more comfortable. The illumination, the lighting is better than Loupes even.
Right, right. It's
Sounded more
self-contained.
comfortable.
Yeah,
Yeah, exactly.
yeah.
I mean, we still, in our group, in the residents, Loupes are still used a lot,
Hmm.
but I think the more options that we have, the better. But for me, my personal preference is the operating microscopes have been much more comfortable, both during when you're doing it and then that night and the next day, for example, after a long case.
Right, right. So well said, Jeremy. I remember that when I first started having kind of this TMJ pain, myofascial TMJ pain, and when I saw one of the oral surgeons, they said, you operate with Loupes. This is not helping this. And I didn't stop using Loupes after those initial bouts of pain because they would get better. And I was always worried that I would lose my sort of outcomes doing endocrine surgery. I was concerned, what if I can't see the nerve as well? What if I can't, see the parathyroids as well? And so I continued using them. Obviously, I had to stop using kind of our standard, as you said, through the lens Loupes when the pain was just, constant and unbearable.
Right.
And you made another interesting point, which is that it's not just during the case or immediately after. You can feel it for a couple of days later. Years of that repetitive injury obviously adds up, and I think it contributes to the epidemic of kind of, C-spine degenerative disease, including disc disease that we see in so many specialties that use Loupes, especially the high magnification Loupes that you mentioned.
Right.
Now, you also highlight an important thing, which is that, us as a group, surgeons as a group, procedurists as a group, we're not very good at listening to what our bodies are saying, unlike you. And maybe it's because you already kind of did spine surgery and knew all the damage that people cause to their spines, that you actually took the discomfort that you were having as a check engine light and then switched to how you did your work, as you said, by using the operating microscope. And I actually know a couple of endocrine surgeons who started using the operating microscope to do thyroidectomies just because of kind of what you mentioned. You don't have to wear a headlight, you have in built-in light, and you have great magnification, and you can sit. That being said, I'm guessing that the microscope also has its own challenges. I remember coaching an ENT surgeon a couple of years ago who was having some shoulder issues related to kind of long-term microscope use. Would you be willing to share some of those challenges? And, how do you now sort of advise your trainees and other surgeons who use the microscope, like maybe ophthalmology surgeons, plastic surgeons, like how can you sort of have the best posture and take care of your body if you're using the microscope a lot?
Yeah, I mean, like you say, there is no perfect system, and the microscope has its pluses and minuses. I mean, they're
Mm.
big, they're heavy, they have to be draped for us to maintain your sterile field,
Good point.
which not all specialties do for different applications or different kinds of scopes. But
Mhm.
I mean, there is a limit on how much they can angle. So if you're trying to look at an acute angle, depending upon how the patient's positioned, or like if we're doing a posterior fossa craniotomy, sometimes you can only angle it so much.
I see.
And then you have to kind of move your body or work at an awkward angle. So, I mean, the best way to mitigate that, just like any kind of good surgery, is planning ahead of time.
Hmm.
How
Hmm.
you position the patient, how you flex the head, how you set up the microscope. So, plan for those kind of angles that you think you're going to need. And I mean, I always make our trainees balance and set up the microscope themselves because they know how am I going to be standing or sitting using this during the case
Hmm.
so
Hmm.
that it's perfectly balanced for that position and not just some generic position that the staff might set it up for. So planning goes a long ways to helping those things. Uh,
Hmm.
and like everything, the scopes have gotten better over the years and smaller profiles and smaller heads over the patient.
Hmm.
But I mean, almost every hospital has a operating microscope and multiple services use it.
Right.
So they're always available in most places. So I would encourage surgeons to kind of check it out and at least look at it and see if
Hmm.
it's helped me or not.
Okay. And then am I correct in recalling, I think when I was coaching that client, I remember looking, you can get attachments too, right? To adjust angles on the microscopes, the operating microscopes, similar to kind of the microscopes that the pathologists use, right?
Yeah.
So,
So you can move it with a foot pedal, you can move it with a mouthpiece that you
oh,
just
okay. Okay.
kind of bite on and move it with your mouth so you don't have to take your hands out of the field.
Hmm. Hmm.
But I mean, you always want it well balanced. So if you keep one hand in the field, you can move it with the other. But there are different options to make it as easy to move and manipulate as possible.
Any advice regarding using armrests or where to kind of put your arms? Because I imagine if you're working, I can see myself kind of if I was at a microscope doing a thyroidectomy and have kind of lock my arms and just move below that and just, keep the fine movements at the wrist. So arm and shoulder issues, how do you prevent those when you're working at the microscope?
Same thing. It's planning. I mean, you always want to be working so your elbows at kind of your hip level, so you're not working too high or too low. Or I mean, it's fatiguing
Hmm?
if you have to hold your arms up in the air.
Right.
Armrests and having that right table height so you can sit or stand or go back and forth and do both. I mean, I've had cases where the angle of the scope is limiting and you are end up with your arms at shoulder level, which is never a good thing for a long
Mhm.
case because you're going to fatigue no matter how long you're in there,
Right.
which is
Right.
bad for steadiness and comfort and
Right.
ultimately
It's
outcomes potentially if you're fatigued and don't have the precision that you want.
Right, right. No, all excellent points because, we still don't have the data showing how we understand how surgeon fatigue and ergonomics could affect outcomes. We don't have that data yet, but I think we will, kind of get there. But we know, I mean, how
Yeah.
things affect our performance. So that's really sort of interesting to hear. Now, we touched briefly on kind of the old loops versus the new loops. So now we have loops with, steep angles of declination. In fact, there are some deflection loops which are almost like operating through the microscope. I've tried them, and I think your scrub tech looks alarmed because the person standing in front of you, it looks like you're looking straight at them, but you're actually looking at the field. What is your advice regarding these loupes? And of course, they're much lighter than they used to be. Is that comparable to using a microscope, you think? Or what would be the situation where you can get away with using these newer loop models rather than the microscope if you don't have availability, for example?
Yeah, I mean, it's most of them are still a fixed angle. So, I mean, obviously you always want your head kind of straight up and down and in
Yeah.
a neutral position for long-term comfort. And
Hmm.
just depends on how deep your field is. If you have a superficial part versus if you're deep in the abdomen, for example, or a foot deeper, then that focal length is going to change and
Right.
have to move your head. So, I mean, I haven't tried them yet myself, but I think if the angle is fixed, you're still going to have to move some.
Right. Right.
Less
Depends on the work that you're doing. Right.
exactly. And how
Okay.
big or how small your field is. And I mean, again, that's patient positioning, patient body habitus, and lots of factors go into it. So you want to just kind of plan as best you can for all of that.
Right. Right. So I want to point out to our listeners, this thing comes up in a lot of the episodes, right? People say, "Well, what can I do?" And what you're hearing is, when we say intraoperative optimization and things you can do outside the OR. And what you're hearing Dr. Greenlee say is similar to what we've heard in other episodes when it comes to, patient positioning, intraoperative setup optimization. You've got to take the time, no matter what you're using, to optimize things and positioning and be aware of your posture at all times. This goes a long way, and trying to keep neutral posture. Dr. Greenlee, what do you think about breaks? Because I often coach people, and obviously we tell this to people who are involved in the Society of Surgical Ergonomics whenever we give talks, etc., that breaks are a key ergonomic intervention, especially because, as you just pointed out, you're not always going to be in the best or optimal neutral posture, whether it's related to your equipment, whether it's related to your patients. As a neurosurgeon, what are your thoughts on taking breaks when you're doing these sort of cases? And do you take them yourself? Do you encourage your trainees to take short breaks and reset their posture?
I do. I mean, it's not too common because I mean most of our surgeries aren't that long, but I mean as a
Mhm.
surgeon, you think, yeah, I can tough this out and I don't need to take a break and those kind of things. But kind of like you said before, I mean, you know yourself and you know what you need and what is ultimately safe and best for the patient. So I think, I mean, you never feel bad about taking a break and not necessarily leaving the field or leaving the room, but doing something to change. If you're sitting, you can stand for a little bit, or if you're standing, you can sit for a little bit. So there's no metric that is going to show outcome differences, but at the end of the day, you kind of know yourself and you always have to do what you know is best for the patient. If that means taking a break and moving around or going to get a drink or something,
Right.
so that you're in the best mental and physical condition to do the best surgery possible.
Got it. And that's that I'm glad you said that last piece too. It's that cognitive break too, right? When you're doing such work with such focus and such precision, it's not just the physical break, but it's that cognitive break that is equally important. I know when I've been hunting around for the recurrent laryngeal nerve for a while, sometimes I just have to step away from the table and come back a few minutes later, and then
Yeah,
I can find it right away. And that really sort of speaks to that cognitive fatigue, as you mentioned.
yeah.
Okay.
Yeah, I
So,
absolutely agree with that. And I mean, it changes your perspective when you come back, and even though you've been looking at the same field for the last 2 hours,
right.
you
Yeah.
walk to
Now,
the other side of the table, or it looks different when you come back.
I agree. I remember when I was a new attending, you start operating from the other side of the table and things look so different. So there is reality in that, that change perspective, as you said. And I'm going to say something for the trainees that might be listening to our episode is that now, listen, guys, you may not sort of believe when I say that breaks are really important, but you heard it from someone who takes care of other people's necks and spines. All right. Breaks are a key ergonomic intervention, no matter what type of surgery you're doing. Now, Jeremy, I do want to kind of spend a little bit of time talking about a couple of other technologies. you actually are the one who pointed me towards exoscopes. I had also heard about them from Dr. Susan Hallbeck. She was studying them at the Mayo Clinic. Can you explain to our listeners what exactly are exoscopes? And, I've seen some data that they can be better from an ergonomic standpoint compared to the operating microscope. So please, if you could share your views on that and your thoughts on that, that would be fantastic.
Sure. So an exoscope is basically a mini microscope. So it's a small magnifying, illuminating device that sits above your field, but it's small enough you can look around it. So the view gets projected to basically a big screen monitor.
Mm,
So it's nice because you are looking straight ahead at a big screen, so the magnification's good. But the advantage of an exoscope that I found is that ability to angulate. You can turn the scope in many different angles, but your viewing in your body and your head is still looking straight ahead at that screen. So there's 2D exoscopes, there's 3D exoscopes. You have to wear 3D little glasses to look at the 3D version. But I remember doing one sphenoid wing meningioma. We were trialing an exoscope at the time,
mhm.
and I said, okay, we'll try this at the start of the case. And I thought, no way we're going to do very much with this thing, and we'll have to convert it or bring in the microscope. But we ended up doing the entire case with the exoscope, which was impressive to me for challenging, complicated case like that. But the visualization was great, the comfort was great. So I think, like I mentioned before, the more tools you have in the toolbox, the better.
Mhm. Yeah.
That you can plan for a given case and a given approach and patient position. But I found exoscopes very helpful to use. I'm still trying to get the hospital to buy one for us,
Right,
which
right.
is a separate podcast.
I think so. I think so. Yeah,
But
so
you can use it for spine surgery, you can use it for brain surgery,
that's
and
what I was going to ask. What are the
even
applications?
less
Yeah.
superficial things that can use it instead of loupes for even more simpler, shorter things. But
Hmm.
I think that's an asset to have.
Right. I think I remember seeing an abstract using it in otolaryngology as well. Because again, when you're in a small space and you need something like a microscope, but then you're hunched over or potentially could be hunched over, this seems the exoscopes, it's like that taking that leap from open surgery to endoscopic or laparoscopic surgery, for example, when your field, instead of hunched over an open field or a
Yeah.
microscope, you are now projecting the image in front of you. And so that kind of takes that postural kind of strain and allows you to look at the screen in front of you. That being said, when we talk about laparoscopy with general surgeons, gynecology, urology surgeons, um, when laparoscopy first started, we started noticing that people had more sort of hand and wrist issues because of kind of that first generation instrumentation. Obviously, it's come a long way. Where does endoscopy, because you do endoscopic surgery, where does that fall into the spectrum of kind of this toolbox that you've talked about on today's episode? Because we've talked about microscope, loupes, exoscopes. Tell me more about sort of endoscopic neurosurgery, skull-based surgery that people do and you do.
Yeah, so there's two main uses of endoscopes
Hmm.
in cranial neurosurgery, at least. One is the endonasal, which is the most common, where it's a purely endoscopic visualization, the whole case.
Pituitary tumors, right?
Like
So,
pituitary tumors is
yeah.
a common use, or any kind of anterior skull-based tumor, sinonasal tumors. So again, there's 2D versions, there's 3D versions, and that's a different learning curve to get used to kind of working with either a two-dimensional view or looking at a screen instead of looking into the field.
Hmm.
But you get used to it pretty quickly. Having an endoscopic background definitely helps you get used to using an exoscope because it's the same kind of a situation.
Right.
So if you're already comfortable doing endoscopy, you'd have no problems adapting to an exoscope.
Uh-huh.
But again, it's a comfortable position where you're looking straight at the screen and you're not kind of flexing your neck a lot. So the other way you can use it in intracranial surgery is called endoscope assisted surgery, where
Hmm.
basically you have a craniotomy or you have an open
Right.
corridor, and it's
Right.
easy to put an endoscope, 4 millimeter endoscope down that same corridor like you do with the microscope, and but it gives you the angled optics with a 30 or a 45 or even higher angled scopes to look around corners to get a last little bit of tumor out. So it's an adjunct to a primarily microsurgical resection.
Section, yeah.
There are some purely endoscope craniotomy cases that can be done, but most of it's used as an adjunct to microsurgery with the microscope.
Okay, got it. So that's very similar to when we kind of do, I'm general surgery trained. So for me, it's like, okay, laparoscopy, you can do lap assisted, as you said, you can do pure laparoscopy as well. And then in the fields that I mentioned, gynecology, urology, general surgery, where we do a lot of laparoscopic procedures, a big turn for our colleagues who do that has been the introduction of the robot-assisted surgery, because they can sit, and then if you're used to doing laparoscopy, thoracoscopy, etc., it's much easier to adapt to obviously looking through the robot. Are there
Right.
any applications of the robot in neurosurgery or in what you do specifically?
Not so much. Not
Okay.
like I mean, we have robots, but they're kind of a different system that's whatever, putting in pedicle screws or depth electrodes, where it's basically kind of a glorified micro drive to kind of drive things in.
I see.
That's very different than like the Da Vinci robot.
Right, right.
And I actually looked at the Da Vinci years ago to see could we use this thing through the nose, for example.
Mm-hmm. Mm-hmm.
So the arms are just a little bit too big and there's too much motion. You get very precise movement on your kind of working tips and the instruments, but to do that, the manipulating arms in the background are moving too much. So
Mm-hmm.
you just
Mm-hmm.
don't have as much space through a small little craniotomy or through an endonasal corridor.
Right, right.
That kind of visualizing and action robot hasn't really been too applicable yet.
Got it. Okay. Well, this is all really, useful information, and I'm always delighted to chat with you about these things, especially when I'm not having a lot of pain and calling you at 10 o'clock going, I don't
It's
know if
always
I
a
want
good
to
thing.
have this procedure, Jeremy. So, in the last couple of minutes, I wondered if I could have you kind of step back from the intricacies of these modalities. What kind of advice would you give to your colleagues like myself and other surgeons who might be facing C-spine, L-spine issues related to their work, maybe contemplating treatments, contemplating surgeries for relief of their symptoms? And as someone in a specialty who probably, you and your partners see those of us who end up in emergencies losing sensation or losing power in various body parts. So, what advice can you share with maybe our younger surgeons and trainees who are listening to this?
The best thing is to take care of yourself. Degenerative spine disease is ubiquitous, and all moving people get it to some degree as we get older.
Right.
But the stronger we can make our necks and our cores and our abs and all that stuff to kind of help support the spine and the discs and the ligaments, long term, I think staying kind of fit and exercising is always a good thing. But strengthening, in addition to just range of motion and conditioning exercises, helps. So
So
any
strength, yeah, strength and stretching, that's what we advise. You got to do both.
right,
Yeah.
yeah. So I think all that stuff sets you up for success inside and out of the operating room. But
And if
again,
you
if you
do,
if you
if,
notice some repetitive pattern, try
Mhm.
to do something to kind of rectify it and not just let it kind of go on, whether that's changing visualization or changing positioning or whatever you can do. But I think that kind of chronic preparation and physical care, I think, helps a lot.
Great advice, great advice.
Easier said than done as a busy surgeon, but
Yeah, I'm not going to ask you what you do, Jeremy. I'm not going to put you on the spot because I tell people I wasn't an athlete. I didn't do anything in particular until all this started. Now I can't, in order to continue sort of my career, first time I talked to you about this pain was 2017, and I'm still operating and I still see you in the OR. So I've had to learn to do these things and take care of ourselves, as you said, first,
yeah.
because, that's what's going to stand you in good stead. And I perhaps,
Everybody's definition of wellness is different. So, fortunately, I have a 15-year-old son who decided he wanted to start working out and going to the gym. So I've
I
been
see.
going with him for the last 2 years. But playing hockey is what I do, and ride my bike to work, and all those things help mentally
hmm
and physically.
hmm
But like I say, everybody's definition of wellness is different. So whatever helps you recharge and make it enjoyable is what we all need to do.
Well said. Well said. Now, Jeremy, this is like I say this all the time, like these episodes just fly by when I'm recording because we have these conversations. And so I think we're almost to the end of our time today. But I do want to take a couple of minutes to again express my sincerest gratitude to you for taking the time out of your crazy schedule to spend some time with me and share some information about these pearls that you have of knowledge regarding the spine. So thank you again.
My pleasure. Happy to
Being
help
here.
and glad to see you doing better and still operating after all these years.
Yes. Okay. Well,
We've
thank
come
you
a
so
long
much.
ways.
Please remember to subscribe to the podcast and follow us on social media, Instagram, X, Facebook, and LinkedIn. We love feedback, so please reach out to us for topics, ideas, speakers, or if you ever want to be a guest on the show. Thank you for listening. To enter your name for the Ergo Angle Deflection Loupes and Headlight Combo giveaway, please go to our podcast landing page at www.surgicalergonomics.com/podcast/ and fill out the contact form at the bottom of the page. Choose Other in the drop-down menu and indicate Loupes giveaway in the message. We will do a drawing for the winner in December of 2025, so please spread the word among your colleagues and friends who might be in the market for new loupes. Thank you.